So one term that you need to avoid after your consultation, if this is all you've got to take home, is you've got a good donor. And the reason I say that is we have a lot of patients write to us who have done their research, had several consultations, sometimes with YouTube doctors. I'm not against YouTube doctors, some are probably very good, but we've had some go to various doctors and their summary is, I have a good donor. This is quite a subjective term. What does it mean? I've had a good pizza, I've had a good meal, I went to a good show. It's very subjective. You do need to try to get real empirical data when it comes to a consultation. If your doctor is unable to read and give accurate density readings of your donor, how good will they actually be at carrying out your surgery? Now, some may be great, but I would just say avoid meaningless terms that really are not transportable into any other clinic. So when you're a 5 out of 10, a 7 out of 10, you've got a good donor, it is pretty meaningless. So try to get empirical data, try to get a doctor that can measure your donor density, look at your miniaturization, look at your follicular unit makeup, i.e. how many hairs per graph that you've got, and just give you that real empirical data as a foundation for you to then plan your surgery. So avoid meaningless terms. They're okay to say you've got a good donor if they can back it up with data. If that's all you get from your consultation, then try not to plan upon that.
We use this trichoscopy tool and to show how we going to measure the safe donor area. Here we're gonna go and check and see how we measure it. So basically we're taking an image of the donor area here in the back, and so as you can see, we can take also measurement on the side. After taking measurement on the side, we will measure and look at every area on this safe donor area. So basically I will check hair in 3 and I'll say even on the fringe there, and we can compare. So as you can see here on the red dot is what we're going to measure now there. On the fringe, what the type of hair that we're going to have will give us an idea of where we go. And then we're gonna go in the nape. And we're gonna go on occipital. Patient, by the way, had a surgery, so you can see some white dot from where we extract some follicles. And then the last measurement will be on the top area here. So now that we have measured and look at different area, we're going to go and look at our findings. As you can see, we have 1 in the nape, 2 in a occipital protuberance, 3 just a little bit above the fringe. So if we take 1 that on the nape, we can, with this software, measure hair caliber versus the number of hair. So we can see that here on the nape, most of the hair are below 40 micron, with actually a lot of them being between 40 and 30 micron. So then we have that as a baseline for our measurement in the nape. So when we go in a protuberance, we can also do the same by measuring with a software here the diameter of the hair shaft. We can see here, once we get around the occipital protuberance, most of the hair are around 50, 40 micron. 40 is here, so 50 is there, and this is the number of hair. So we have most of the hair around that, but we have a distribution on this ghost curve where we can say the average will be somewhere around 40 micron on this patient. And then when we go just a little bit, this is a number 3, and our number 3 is here. We know that the fringe was there, but we are almost 2 centimeter there, and we do the same by measuring the diameter of the hair shaft, and so we can see we still pretty much closer to the 40 micron diameter average of our hair follicle. And then we go right there where we start seeing the crown dipping. We can measure also the hair follicles there and see the diameter of the hair shaft. And as you can see, we still closer 30 microns. So the hair there at the border are almost the same diameter than the hair in the nape. So this patient is taking medication. His family history, yes, he has a family history of baldness, but what we also going to look at is the hair pigmentation, the coloration, because we know when we start losing our hair, not only the hair, the diameter starts shrinking, but also the hair starting changing the color. And when we look at here, we pretty much have a lot of darker brown hair, a few miniaturized hair, but we are here in the middle occipital area. And when we look at the area above, we can see that we have more lighter hair. I can put that here. We have more darker hair. Here we have more lighter hair. And so we know also when we start looking, we look also at the miniaturization that we can see. Yes, the software can measure, but we can also visually look at the number of miniaturization around here. We can see the diversity in terms of hair diameter and also the coloration of the hair while we looking at our hair. So here we can clearly see that we have a change in hair diameter, we have a change in hair coloration, so we'll be careful not to harvest hair there. So for me, when I have that, I know that this is exactly the area that I should not go. So for me, I would say the safest donor area in this case for this patient, we should not go above this area here. So I'll go in between and take also a look at the hair in between there, just to make sure that we don't have a lot of discoloration and a lot of miniaturization there. So this is exactly what we're going to do by going there and looking at our donor area here. So then we go back. This is number 5. We see that we can see that there are some miniaturization, but the coloration is still good. And when we run the software here, like we did with other area, we can clearly see that we still have a lot of hair around 40 micron, very little hair around 30, 20, and 10 micron. So we feel comfortable harvesting hair around this area. So this is how I personally check safe donor area. So as you can see, you cannot have a rule for safe donor area because it's going to depend from each individual. So it's important to analyze the donor and to analyze the donor of each patient to make sure that when we look at the donor area, we take every patient as a unique, and we don't just have one set of temple or template for everybody. Everybody is different. Everybody has his own family history. Everybody do not take medication, so it's important to analyze every step. So especially the superior border of the safe donor area.